Hello everyone, it's me again, Nurse Kinan. I'll be with you in learning maternity nursing too. And today I'm going to present a material created by Nurse Bellet titled Reproductive Problems with Bleeding Disorder. So we're going to talk about bleeding disorder in pregnancy, which can happen in early pregnancy bleeding and even at late pregnancy bleeding. And there could be also a postpartum bleeding, and which will lead to hemorrhagic shock, and it could also possibly happen because there is a blood clotting disorders that occurred in the mother during her pregnancy. And bleeding in early pregnancy can happen when there is the implantation, and there's also spontaneous abortion can also happen because there is an ectopic pregnancy, can also happen because there is hematoma intrauterine, as well as when the pregnancy is a molar pregnancy. And this can caused by various factors such as abortion, there's ectopic pregnancy and molar pregnancy. Well, what is abortion? Abortion is a condition when there is expulsion of the products of conception before the fetus can live outside the womb, namely when the fetus is less than 500 grams or the gestational age is less than 20 weeks. And the risk factors include endocrine factors, genetic factors, immune factors, infection, and uterine factors. With the with endocrine factors, there will be like deficiency in progesterone, or there is thyroid disease on the mother, or even uncontrolled diabetes mellitus. With the genetic factors, which then accounts for about half of the spontaneous abortion, it is just because of hereditary line of the mother. With the immune factors, it's because there is a syndrome of antiphospholipid and also the disease of SLE. And with infection, there could be a lot of infection that could trigger abortion, such as chlamydia, gonorrhea, herpes, listeria, mycoplasma, syphilis, toxoplasmosis, as well as chemical exposure and radiation exposure. With the uterine factors, abortion can happen because the size and the shape of the uterine, such as retroversion, or there is myoma inside the uterine, and there is also probably abnormalities in the uterine that happen congenitally that is not being detected before pregnancy happen. And in abortion, we have to note how much is the bleeding. So you have to teach your patient, is it just a scant amount, or is it just like amount, or is it a moderate amount, or even a heavy amount. So this is very important to let the patient understand during her first trimester, so she can then have the awareness to understand that probably she is going through abortion if she is bleeding through her pregnancy. So there are a lot of classifications of abortion. So the spontaneous abortion, and it can happen because of chromosomal alteration, and it can happen also because the uterine abnormalities. For example, the shape of uterine like this, so it's not like one cornice, but it's bicornice uterus. And also probably the mother is having autoimmune problems, so it trigger abortion on the pregnancy. So we will talk about imminent abortion first. So imminent abortion is early stage of abortion and a threat of abortion, which characterized by vaginal bleeding, closed uterine ostium, and also the products of conception still well in the womb. And we have what we call incipient abortion. So it's a threatened abortion characterized by the cervix having flattened and the uterine ostium opening, but the products of conception are still in the uterine cavity and in the process of being expelled. We will see the pictures of this later on. So another classification for abortion is what we call complete and incomplete abortion. So incomplete abortion is when there is abortion, but the product of the conception before 20 weeks, some remain within the uterus. So it's incomplete. So because of the attachment of the fetus to the wall of the uterus, but it is abortion. So some part of the baby already get out, but then there is still the remaining of the conception products within the uterus. And then with the complete abortion, suddenly there is the expulsion of the conception products, which is the fetus, and at certain time, like all of a sudden, the cervix just open and then all the products of the conceptions then just being expelled through the vagina. So the mother will experience a lot and heavy bleeding and with the complete abortion. Meanwhile, with the incomplete abortion, the mother will experience bleeding, but it's not like heavy bleeding. So it's just a little, and then an ultrasound needs to be done to check whether it is a complete or incomplete abortion. So another one is the one that we have to talk about is what we call threaten. So the threaten, um, what happened is that there is an abortion with just a little bleeding, and there is no sign of growth of the fetus. And then with the inevitable, what will happen is that it's still attached, but then part of the conception of the part of the fetus that is growing is already being expelled through the cervix and come out through the vagina as bleeding sign. And with the incomplete, um, like half or there is expulsion of the product of conception, but there is still a little remaining inside of the cervix, which we need to take out from the curettage or even by dilation of the cervix to get every part of the fetus out. And then what we call the complete abortion, where I mentioned before that the whole product of conceptions just go through the cervix because the cervix is weak or other triggering factors that cause the abortion. And then we have what we call misabortion. So misabortion is actually the fetus is already aborted itself because of various reasons, but then we did not see any bleeding. So what we need to do is the mother will do ultrasound and it will be found that there is an abortion which is not causing any bleeding. So the abortion is actually characterized by the death of the products of conception inside the womb. There is no increase of the height of the uterine fundus, and there's no vaginal bleeding, there's no cervical opening, and there is no uterine contraction. So it's just perfectly stop growing, and then we have to check it through ultrasound. And there is what we call habitual abortion. So it's a spontaneous abortion that occurs 3 or more times in a row. So it's a pregnancy, and then there's an abortion, another pregnancy, and then there's a abortion, and another pregnancy again, and there is the abortion. So we have to figure out what is the underlying factors for the abortion, so we then can help the mother and the father to then maintain the pregnancy until the full term. Another classification for abortion is what we call infectious abortion. So this is an abortion that accompanied by infections of the genitalia area. And another thing is what we call septic abortion. So it's a severe infectious abortion that accompanied by a spread of germs or toxins into the bloodstream or peritoneum. Because of this type of infection, then the baby died and the mother is going through abortion. So what happened? There is pathogens, can be virus, can be bacteria, and the bacteria can trigger the productions of peptide as well as the virus can trigger the activations of macrophages and T cells, and then this will then increase the cytokines and as well as uh, cause the activity of chemotactic. And this is the normal process of the body when there is infections going on inside ourselves. But then the neutrophils will then be attracted to come into the sites of infection, and then the mother will then create within her body an excessive maternal immune response that will then also think that the baby is also the part of the infection itself, then will cause abortion. So yeah, this is a common thing. That's why we always provide educations to the mother, even the father, that during the pregnancy, the mother and the father needs to be healthy. They need to take a lot of vitamins. They need to make sure that they are healthy. They don't get caught with any infections, even with a common cold or cough. So yeah, that's the reason that will also trigger the abortion to happen. Then the next one, we have what we call ectopic pregnancy. So what is ectopic pregnancy? The definition of ectopic pregnancy is actually a pregnancy in which the ovum has been fertilized, but it does not grow or is not being implanted inside the endometrial wall of the uterine cavity. So as we know, once the sperm meet the egg, then the fetus needs to travel through the fallopian tube, and then it will be then implanted to the uterine wall, the endometrial wall or inside the uterine cavity. But then this not happen that way. So the ovum it travels somewhere else and it implanted somewhere else, and we call it ectopic pregnancy. So the risk factor for ectopic pregnancy includes the use of contraceptive. There's a history of ectopic pregnancy before, and then there's this history of uterine exposure to diethylstilbestrol, and there's the history of genital infections such as PID, chlamydia, or gonorrhea, and there's also a history of tubal surgery such as tubal ligation or tubular anastomosis after tubal ligations, and even in vitro fertilization. And there's the infertility and also smoking. With the use of contraceptives, sometimes um, it's hindered, especially when you have the T Cooper. So it hinders the fetus to the ovum to just attach into the uterine wall. History of ectopic pregnancy increase another chance for having ectopic pregnancy, as well as when the uterine is exposed with the diethylstilbestrol, so it's not that easy for the ovum to attach in the uterine wall. And infections, as we know before, it can also trigger the body to treat ovum as part of infection. That's why the pelvic inflammatory disease and chlamydia and gonorrhea will then be the risk factor for ectopic pregnancy, as well as tubal surgery. So the fallopian tube that has been ligated before, and it then be reanastomosis. That's something that can also trigger an ectopic pregnancy, as well as when we do the IVF, so that the ovum that is being inserted to the uterine, it cannot easily attach to the uterine walls, so then it causes to be an ectopic pregnancy, as well as the cause of infertility. So something happened in the uterine cavity that we cannot understand, and then somehow the ovum cannot attach there, and it's just attached somewhere else within the abdomen of the mother. Well, the history of smoking also then increase the problem for having ectopic pregnancy because of the chemicals that is within the cigarette itself that's triggered the woman to not being able to have a normal pregnancy but ectopic pregnancy. So this is the picture of where the ectopic pregnancy can happen. So a normal one will be within here, like around this part of the uterine. And then, well, let's talk about how it happens. So the sperm will travel inside the cervix, and then the egg will be expelled, and then they will meet. And normally, the ovum needs to attach somewhere here, like within the uterus wall, within the uterus, at the endometrial wall over here. But then there's the problem. It cannot attach there because of the risk factor that we have learned. So then it can be like out of the uterus itself. It's just within the vagina, within the abdominal, and even by the um, cervical openings and at the cesarean scar, so it will have scar after C-sections within the uterus, and the baby will attach there and cause what we call ectopic pregnancy. And also, attachment can be an interstitial and corneal, even isthmic, so by the fallopian tube, and ampullary, like by the near the fimbriae, and also fimbrial. So instead of like traveling back to the cervix, to the cervix inside the uterus, um, the ovum then just stay within the fallopian tube, and even can also attach to the ovarian. Yeah. So all of this can be known through ultrasound. So that's why it's important to let our patient knows that during their pregnancy, they really need to do at least one ultrasound in first trimester, then two ultrasounds on a second trimester, and three ultrasounds on their third trimester. So what's the clinical overview for ectopic pregnancy? So it is difficult to detect undisturbed ectopic pregnancy because usually this type of pregnancy did not cause mother to complain of anything. But then once the mother have the pregnancy, the mother will then uh, show the symptoms of early pregnancy, such as nausea, enlargement of the breast, which accompanied by pain, and then also amenorrhea. So there's no menstruation, and then the mother will experience all the early pregnancy symptoms, and then she will then um, check herself to the OBGY and then figure out through the ultrasound what is happening with her. Another thing is that if the ectopic pregnancy then become complicated or there is a rupture in the tube where the nidation is located, then this will give typical symptoms and signs such as severe abdominal pain and then following by the shock and fainting. So the first one as the symptoms of ectopic pregnancy will be the mother will feel weakness, there will be heavy vaginal bleeding, there will be rectal pressure, and there will be the tenderness in the cervix, as well as there will be a severe pain on the pelvic region, unusual pain. So, if there is this typical sign of severe abdominal pain followed by shock or fainting, the mother become weakness, have bleeding, rectal pressure, then this is the typical sign of disruptive disrupted ectopic pregnancy, or what we call kehamilan ectopic terganggu. What's the treatment for ectopic pregnancy? So what uh, we can do few treatment. The first one is actually surgery. So surgery is the primary treatment for ectopic pregnancy. So we'll see where the pregnancy is located, and then either through cord dilation and curettage, so DNC, we will try to get the pregnancy out, or we have to do like surgery to really like open up the abdomen and get the babies out before there is abortion or a rupture in the tube. And another one is what we call salpingectomy, because if the pregnancy, the tubal ectopic pregnancy rupture, for example, the baby is located here, and then this is ruptured. So we just have to cut this because then it causes too much intra-abdominal bleeding, and it needs to be treated immediately. If it not happen, then we will do therapy using medicine. We call it methotrexate, and then this will then uh, shrink, and then the body will then absorb the pregnancy. So yeah, so we have to educate the mother about the expectant management through this, and then as well as the following up monitoring. This is a phase of losing a pregnancy, but we have to educate our patient that this is not a normal process of pregnancy. So before the pregnancy cause any bleeding, uncontrolled situation, so we have to take control. And some mothers will go through um, the phase of grief and loss, and as the healthcare professional, we need to really be with the patient, and then we need to provide encouragement and provide hope that there will be another pregnancy. And yeah, being through the process, and then and acknowledge the feelings and the anxiety as well as the sadness that may be uh, felt by the mom as well as by the father. We move on to what we call molar pregnancy. So molar pregnancy is like this. This is a normal pregnancy. So the embryo will be planted within the uterus, and then it will grow as a baby. But in molar pregnancy, what happened is that there is a pregnancy, but it is not the pregnancy. It's actually a fluid-filled cyst called tumors. So the filly will grow up so excessively, and there will be a lot of thing inside the uterus mimicking pregnancy, but it's actually not a pregnancy. So it is actually the abnormal proliferation of the chorionic villi, and it's a premalignant disorder of gestational trophoblastic disease, or PTG. And this is the very common and benign situation called a molar pregnancy. And it occurs within 100 population, one or two cases. So it's very rare, but when it happens, as a healthcare professional, as a nurse, we can notice that, yeah, this is a false pregnancy. So it's not a true with embryo inside of the pregnancy. And what is the clinical manifestation for this pregnancy? So there will be an abdominal growth of the uterus. Mother will experience nausea and vomiting. There will be vaginal bleeding as well as high blood pressure. And yeah, it's similar with pregnancy. So there will be amenorrhea and the form of bleeding will be a dark red or bright red, and also there will be hyperemesis gravidarum. So again, this can only be seen through ultrasound. So again, the mother needs to see the OBGY, and then the OBGY will do ultrasound check, and then it will be figured out then if that's a molar pregnancy or ectopic pregnancy. If it's a molar pregnancy, the diagnosis will be done through health assessment, history taking, as well as physical examination. So what we find out is that we will be asking of the history of late menstruation with several menstrual cycles from the patient, as well as the mother is feeling that there is a pregnancy, but there is no movement of baby inside her abdomen. Um, and what is actually inside her abdomen is the villi. So it's a lot of villi that mimic the pregnancy. And then when we do physical examination, we figured out that the size of uterus is larger than the gestational age. And also there is no definite signs of pregnancy such as ballotment, and fetal heart rate. So when we try to see the fetal heart rate, there is no fetal heart rate. And we can also do the ultrasound and as well as a laboratory examination for urine and for serum SCG in urine as well as the total serum, and we'll figure out that it's more than um, 100,000 for the HCG level in urine, and the serum HCG level be more than 1 million. So what do we do to manage the molar pregnancy? So as you know, this can be called as Hidatidiform mole and consists of 4 stages. The first one is to improve the general condition because the mother have a lot of nausea and vomiting, so we manage the nausea and vomiting first, and then we remove molar tissue by the OBGY by the treatment called vacuum curettage or even hysterectomy. So we use the curettes to remove within the uterus. So there will be a speculum going through the vagina, and then it will see the uterus, and then the curette will come and try to get um, all the things inside the cervix out. The other thing is what we call hysterectomy. So if this caused a lot of problem, then we remove the uterus subtotal. So we just remove this uterus, leaving the cervical here, and then also leave the fallopian tube and then the ovaries. If we do a total hysterectomy, it means we take out all the part of the uterus. And if we do total hysterectomy with bilateral salpingo-oophorectomy, so we take like the both of the ovaries and the fallopian tube as well as the uterus, we just remove everything out. And what we call also Wertheim's hysterectomy, so we took a little part of the vagina out. Yeah. And the next phase is we do a prophylactic therapy with cytostatic, and then we continue do the follow-up. Yeah, because 20 to 30% of the mother post-complete molar pregnancy can experience malignant transformation into gestational trophoblastic tumor. Now, the complication, as I mentioned before, there will be gestational trophoblastic disease, which can be benign, which is the molar pregnancy, which can also be malignant, which what we call choriocarcinoma. So it will be cancer on the side of cervix, as well as fallopian tube, as well as what we call tropoblastic tumors. So it will be inside the uterus, there's a tumor, and we have to remove everything. Well, this is the non-malignant complications as well that can happen, such as uterine perforation, bleeding, disseminated intravascular coagulation, trophoblastic embolism, and cervical or vaginal infection. And there is also malignant complication, as I mentioned before, the choriocarcinoma, this one. All right, so that are all our materials for today. I hope you learned something. Feel free to ask questions, and there will be journals that you need to read and also reflection that you need to submit. Thank you.